When discussing harm reduction, we must first focus on the human and socio-environmental dimensions of people who use drugs and the community of which they are a part. Isolating and criminalising the individual affects the whole of society. Preventing disease costs less than treating them. The intersection and defence of the rights of people who use drugs establishes protections that also cover people unrelated to drugs and addictions. A significant reduction in crime can also redistribute resources to the community, which otherwise experiences no economic return from the huge legal and prison costs. I would begin by addressing prohibitionism and the systematic criminalisation of drugs and the people who use them. Although there have been some improvements, we remain largely within a framework of repression. The logical consequence of prohibitionism is the legitimisation of discrimination and social exclusion. The term stigma is often used as a polite substitute for what is in reality discrimination. Supported by unlimited budgets that began as a war on drugs has evolved, through a punitive judicial system, into a war on those most affected by its consequences, people living with addiction. The barriers created by stigma become almost unsurmountable. Shame severely limits a person's ability to access services and support, effectively eliminating opportunities for self-determination and participation in public discourse. I believe that these issues are more effectively approached with humanity and compassion. The focus should always be on the human element. Subjects are isolated, vulnerable, and descending into problematic drug use. Many are using drugs in unsafe and unsuitable environments, without access to knowledge about hygiene or safer injection practices. This dramatically increases physical and mental health risks, including infections, amputations, and death. The main question is really split into two. What can be done to help? And equally important, what do we mean when we say help? Let me start with this. Harm reduction means supporting individuals who may not yet be able to help themselves. I do not attempt to force someone to stop using drugs, because I understand that compulsion does not depend on me as a worker. Instead, we provide people with the tools that they need to reduce risks and stay alive. Only later, once the person is safer and more stable, can we begin to offer the tools necessary for healing and self-care. These are the foundations that allow a person to ask for help. I do not believe there is a single, universally agreed upon definition of addiction as an illness. The most visible external signs are compulsion and obsession, topics that could be debated endlessly. However, for any discussion to be constructive, we must begin from shared values. 1. Addiction is a disease, and like all diseases, it causes suffering. 2. Drug use itself is not the disease. It is a symptom, a response to profound human suffering. 3. The person must be valued at every stage of their journey. 4. No one recovers after death. The right to survival must always prevail over prejudice. Core principles. 1. Beyond medicalisation. We do not need medical expertise to recognise suffering. Regardless of education or professional background, we can empathise with the experiences that lead to marginalisation and discrimination. Trauma may be hidden behind defence mechanisms, but the pain of the present, along with hopelessness and lack of trust in the future, is clearly visible. 2. Emotional regulation and trauma. Trauma often generates overwhelming emotions, stress, and anxiety. Substances are frequently used as a form of self-medication to numb this pain. trauma becomes embedded within years of coping mechanisms, where everything is deeply interconnected. Too often, therapeutic approaches focus exclusively on abstinence, excluding trauma-informed or integrated therapies. In this context, treatment cannot be limited to recovery alone. It must include harm reduction, with the same compassion we reserve for chronic and recurrent illnesses. People who use drugs often carry long histories of stigma and harm caused by a discriminatory society. Many avoid hospitals and services because they know how they will be treated and the questions they will face. Questions that frequently re-traumatize them. They also know their substances may be confiscated or their access interrupted, increasing risk rather than reducing it. 3. Valuing people as they are. Valuing people who use drugs means accepting them without imposing abstinence as the only acceptable outcome. Treatment may simply involve providing safe spaces and the means to use drugs with reduced risk and without stigma. Compassion and inclusion create the conditions for self-care, greater engagement, and improved adherence to treatment. Special attention must also be given to people receiving opioid substitution therapy, such as methadone or buprenorphine, who are often forced to queue, plead for medication, and endure inconsistent access. These practices increase the risk of overdose due to inadequate receptor saturation and instability. 4. Recovery and integration. Surviving addiction is difficult. Entering rehabilitation is even harder. Yet maintaining recovery and avoiding relapse can be the greatest challenge of all. Social factors such as employment, volunteering, and meaningful engagement are crucial in supporting recovery journeys. Working alongside people with lived experience enriches all of us and strengthens the communities we serve. As a person with lived experience, I am an expert of surviving in a broken system. My knowledge comes not only from theory, but from life itself, from my own experiences and from the extraordinary people I have worked with and continue to work alongside. My understanding is largely empirical, shaped by trial and error, reflection, and shared learning. I am profoundly grateful to those who came before me and developed the harm reduction model. Without their courage and commitment, I would not be alive today. With love for the services we provide and for the work we do.